Good evening, everyone. At the outset, I would like to congratulate and on behalf of all of us, thank the organizers of Musk and this conference and Professor Ravi for bringing his work here. It was a wonderful days and scientific sessions. And special thanks for asking me to be here and participate in this wonderful sessions. Now what is this? Dr. Poo showed a similar one and said it is not the bottom. So the organizers have very systematically done the day. Coming from the top, the heart, the abdomen, and finally the bottom. So they have made me to talk on the bottom at the last. So this is the bottom, and this is not the normal bottom. You will see what is it. Now fetal anus, ultrasound visualization. The technique is you start as an axial scan of the pelvis and go to the perineum, adjust a little to get a tangential scan and see the tangential scan of the perineum to look at the anus. So that is the technique. First start at the pelvis where you see the urinary bladder and then come down, you get at the perineum and take and adjust a little both the probe this way and rotatory movement to get at a tangential scan of the perineum and where you will see the bottom well and you will see the nice anus as a Nekopoor ring with a central dot. So that is the technique. You will see the, and I want to show this the image of an adult woman, anus of an adult woman seen by placing the endovaginal probe in the distal vagina, and you all are familiar with this image. So that is the nice anus of an adult woman seeing with the endovaginal scan, and that is the similar appearance you get in the fetus. So this is the Nekopoor ring is produced by the internal sphincter complex, and the central dot, echogenic dot, is the lumen with the mucus and the mucosa. And you can see the video of the technique. You start from the pelvis, come down, make slight adjustments, and you see the perineum with the nice dot of the anus, Nekopoor ring with the dot of the anus in a male fetus, and in a female fetus, starting from the pelvis again, you see the go to the tangential scan of the perineum and you see the nice anus there as the Nekopoor ring with the central dot. So that is the technique. And finally, I am showing you a very simple technique. You have been listening to the very complicated ultrasound techniques from the morning. So for a change, this is a very simple technique, nothing more, no extra time involved. So it is part of your routine examination. You see the external genitalia. So with a slight modification, you see the bottom well and you see the anus nicely. So if you have any difficulty, you have a doubt whether you are not seeing the anus or some difficulty, of course you can use, particularly in the initial part of your beginning to do this, you can use the high frequency and look for the anus, which is well seen compared to the convex probe. And you can also take the sagittal scan. You can see the sagittal scan. You can see the perineum very well. You can see the posterior part, the rectum with the mucosal folds, and that is the anal canal. And in sagittal scan, you see the Nekopoor tube with the echogenic center, the lumen, and anteriorly the structures will be different. You will see the bladder and urethra depending upon the, and also you see in the females the vagina. You can also take a coronal scan. Again, you'll see the rectum, fluid-filled rectum, and the anal canal as an echopore tube with a central echogenic line. So this boosts up your confidence initially to tell whether the anus is present or not. So we come to the abnormal part, so when the anus is not seen. So the same technique, you come down and you see the perineum, and you fail to see the echopore ring with the central dot. And instead you see the median raphe, the line, echogenic line, which was similar to the image shown by Dr. Poo about the brain. So both the top and bottom are similar. So that is the video. You can see that is a male fetus. When you come down, you see the perineum, and the same technique, you fail to see the anus. So are you convinced? Yes. So that is the anus. You fail to see the anus. So when you fail to see the anus, then what do you do? What is your inference? Now, period of gestation. When can we see the anus? From 16 to 37 weeks. That is not important. What happens? We see the anomaly scan between 18 to 22 weeks, which forms the bulk of the scans we do, forms the 70% of scans. And in that 70% of scans, it is consistently seen, almost always seen. That is very important. So when the anus is not seen, what is the inference? Now, it is not seen in urorectal septal malformation sequence. Now, I thank Dr. Suresh for briefing the embryology. You all are now familiar with the embryology. So when the urorectal septum fails to come down and meet the cloacal membrane, we get the urorectal septal malformation sequence. And the other anomalies can be part of anal, the non-visualization of the anus can be part of a vactral sequence or OES complex, otherwise the cloacal exstrophy, or it may be isolated. Now, URSM sequence may be complete or partial. In complete, there is no perineal opening. In partial, there is a single perineal opening. Normally, there is in males, we get the urethral opening and the anal opening. In females, we get the urethral, vaginal, and anal opening. So if you don't get any perineal opening, it is complete URSM sequence. If you get one perineal opening, it is partial. And previously, these are the different words which have been used to describe this sequence. Now, complete URSM sequence, there is no perineal or anal opening. And in this fetus, at 16 weeks, you see bilateral hydronephrosis, and you see a cystic structure in the pelvis. And is it bladder? It may or may not be, but it is against bladder. You see the thick walls and echogenic wall of the, that is the cloaca. And posteriorly, you see a dilated colon with meconium, a ball. So in this situation, you see there was oligohydramnios, but still managed to see the perineum, and there is no anal opening. Anus was not seen. So this is URSM sequence, and at autopsy, there was no perineal opening. It was a it was a complete URSM sequence. Now, we cannot make out antenatally because we cannot see the perineal opening. So it is done by, whether it is partial or complete, it can be determined only at autopsy. Now, the partial URSM sequence is more important because of the spectrum of appearances we see on antenatal ultrasound. Now, here you see one of the appearances. Both the kidneys appear brightly echogenic, so they are and small, completely dysplastic kidneys. So when they're dysplastic kidneys, you still see a bladder. When the kidneys are dysplastic, you don't expect to see a bladder. So is it bladder? No. So you see the shape. It is not like a bladder. You see the pyriform appearance. So you must think of URSM sequence and look at the perineum. You fail to see the anus. So it is partial URSM sequence. Now this is another spectrum. You see hydronephrosis, and you see a septated bladder on coronal scan and failed to see the anus. Again, partial URSM sequence. And here bilateral hydronephrosis, you see the bladder, but you see a dilated colon with meconium and no anus. Now here you see one of the kidneys is agenesis, other kidney is hydronephrotic. Still you see the bladder, but there is a cardiac anomaly and you fail to see the anus. So that is the aborted fetus showing no non-visualized anus. Now here there is bilateral hydronephrosis. The bladder looks normal. It even contracts nicely, emptying. But very important finding is the ambiguous genitalia. And you go a little behind, you fail to see the anus. So the spectrum is different, varying in partial URSM sequence. And if you fail to see the anus, you cannot be complete in your diagnosis. You will say it is bilateral hydronephrosis. That's all. Now here, and sometimes the findings may be very subtle. Here you see just an ambiguous genitalia, no other finding, but the anus is not seen. So this makes just one finding of non-visualized anus, the prognosis is completely different. Then coming to the other group of anomalies where you don't see the anus. It can be a component of vectoral anomaly, and here you see radial ray aplasia, renal agenesis, ambiguous genitalia, and non-visualized anus. This is one picture of vectoral anomaly, and the other is there is polyhydramnios. Still you see the stomach, but there is a blind esophageal pouch indicating esophageal atresia with tracheoesophageal fistula, a cardiac anomaly, and non-visualized anus. So with these anomalies, additionally, when you see that the anus is not visualized, then you are diagnosing a vectoral complex. Now, other group is the cloacal exstrophy, which Dr. Suresh talked in detail. So again here, he said that most of the, the prenatal diagnosis is not very well done, and many are missed. There it is, the visualization of anus is very important, which helps us to pick up more and more cases of this complex. And here you see omphaloceal, the spinal anomaly, and you fail to see the anus. And that is the specimen. And bladder exstrophy with it's not anal atresia, it is cloacal exstrophy. Here you see bilateral hydronephrosis. You fail to see the bladder and fail to see the anus also. So that is exstrophy of the bladder along with the hindgut. Now with spinal deformity, when in fetuses showing spinal deformity, it may be part of vectoral or it may be isolated. So here you see a hemivertebra and anus was not seen. So then you are in favor of vectoral complex as opposed to this fetus where there is a spinal anomaly but the anus is normal. Then we come to the last group where you see colonic calcification, the meconium calcifications. These are two examples. In case 1, so when you see this, straight away we tend to diagnose anal atresia with fistula formation with the urinary tract. But I'll show you these two examples. In case 1, the anus was not seen, so confirmed that it is anal atresia with a urinary fistula. But in the second case, you see the high frequency, the colonic calcifications are seen, but the anus was visualized and it was normal. Even in the sagittal scan, you see the nice anal canal. So this is normal sinus and it was normal. The fetus was normal postnatally and the meconium was granular. That's all, and the fetus was otherwise normal. So visualization of anus was very important in this case. Another case, similar case showing a normal anus. So to conclude, visualization of the fetal anus is useful in diagnosis of URSM sequence. In spinal deformity, when you see a spinal deformity or esophageal atresia, whether it is part of vectoral complex or not, when you see omphaloceal, whether it is a extrophy complex or not, in colonic calcifications, whether it is anal atresia or not. So the fetal ANS is consistently and easily seen at 20 weeks. That is very important. So can be included in the guidelines for anomaly scan. Thank you very much for your patience here.